This is a brief review of the respiratory medications not covered in Part 1 of Pharmacology Review. The first group we're going to cover is the antibiotics. Remember that antibiotics are only used for the treatment of bacterial illness. However, most pneumonia is bacterial. There are some fungal and viral strains, and we'll talk about those. Diagnosis is made based on symptomology, imaging, and specimen collection, such as that sputum specimen. Antibiotics for respiratory disorders are given IV or PO. If IV administration is given, it's usually followed by a course of oral antibiotics for a term of about 10 to 14 days. If the pneumonia is treated with oral antibiotics only, it will usually be given for that full 2 weeks or 14 days. We classify pneumonia especially as healthcare acquired pneumonia or community acquired pneumonia. Healthcare acquired pneumonia is typically a little more virulent and will oftentimes require IV antibiotic administration. That's why it's so important that we have to ensure that we're not sharing those respiratory illnesses in the hospital setting. The antibiotic classes, as a review, are penicillin, cephalosporins, tetracyclines, macrolides, aminoglycosides, quinolones, sulfonamides, and the anti-tubercular antibiotics, which we will also cover. Generally speaking, for upper respiratory infections, most often cause is the bacteria Strep pneumoniae. The treatment is typically amoxicillin is the first line of treatment for this type of illness. Amoxicillin belongs to the penicillin class. If the patient has a penicillin allergy, they will typically be prescribed the macrolide clarithromycin, which is Biaxin. If we're dealing with a pneumonia, it can be caused by a variety of different organisms. Strep pneumoniae is probably as well as Streptococcus aureus are probably the largest bacterial origins. It can be Haemophilus influenzae as a cause, Klebsiella, Legionella. Pneumonia is typically treated by the fluoroquinolone levofloxacin, which is Levaquin, or the macrolide azithromycin, which is brand name Zithromax, or the macrolide doxycycline. It can also be treated with the cephalosporin ceftriaxone, which is Rocephin, or piperacillin, which is brand name Zosyn. Recall that the most important thing about antibiotics is that they need to take the whole course. It needs to be finished every dose on time for the prescribed amount of days. This is to prevent resistant strains of bacteria. Make sure that if you have an order for a specimen, a sputum culture, that you collect that before the administration of the antibiotic, and understand that typically diagnosis is made based on the things that we mentioned before: symptomology, imaging, and then specimen collection. So before we have our specimen results, we're going to begin empiric treatment, where we're going to give the most likely drug that's going to affect the organism. Once we get that sensitivity back from our specimen collection, we might change to a more sensitive antibiotic for the treatment of that bacteria. Moving on to antifungals. Systemic fungal infections can actually be pretty serious. So this does include respiratory infection caused by a fungus. Respiratory fungal infections are treated with these antifungals: fluconazole or diflucan, itraconazole or Sporanox, and caspofungin or Cansidas. These infections, like I said, can become very serious, and in that case it's treated with IV amphotericin B, brand named Fungizone. This medication is reserved for life-threatening conditions or fungal infections due to the side effects, which are very damaging to the kidneys, liver, blood cells, and electrolyte balance. So we will be monitoring labs that are connected to each of these things while on this medication. Fungal infections are most of the time are opportunistic and happen mostly in people that have decreased immunity. One specific fungal pneumonia that occurs in AIDS patients, which is Pneumocystis jirovecii, can actually be very fatal if people that have AIDS contract this type of pneumonia. Other common fungal infections that can happen to virtually anyone, especially those that do have decreased immunity, are histoplasmosis, which is from the fungus Histoplasma capsulotum. It comes from soil and from the droppings of bats and birds. And then aspergillosis, which is caused by the fungus Aspergillus. So these can cause some pretty significant respiratory disorder and life-threatening systemic issues. Antivirals, of course, are given for the treatment of illnesses that have a viral cause. So viral infections are typically treated with symptom management. They're considered self-limiting, which means they will run their course of a certain amount of days, and then the body will be able to overcome them. When antivirals are given for a respiratory infection, it will lessen the symptoms and shorten the duration of the illness. Hopefully, people tend to have different responses to the administration of antivirals. Zanamivir, which is Relenza, and oseltamivir, disregard that 5, it's a typo, Tamiflu, are given to treat influenza A and B. So Tamiflu is an oral administration and Relenza is an inhalation. Now, it's very important that if we are using these antivirals, they have to be given within 48 hours of the onset of symptoms. At that point, if they're given after that 48-hour window, they're proven to be very ineffective. And most of these medications are quite expensive. Sometimes it's difficult to explain to patients, I know you have influenza, but we're on day 3, 4, or 5, and administering antiviral is going to be costly and is not going to be helpful. This is also a conversation that is often had when people have viruses when they're requesting antibiotics, and we have to explain that they're not effective on that type of illness. There are studies that are being conducted that support the use of antivirals in lots of different respiratory illness, including those that are not influenza or RSV, which we're going to cover. But for the time being, the big ones that we're treating are going to be influenza A and B, and then RSV. Another medication in addition to Tamiflu and Relenza is amantadine, brand name Simitrel, and it is given just for the treatment of influenza A and B. It's an antiviral, but it's also a dopamine promoter, so you might see it used in the treatment of Parkinson's disease as well, which is interesting. So influenza A and B is simply referring to different strains of influenza. The best thing that you can do as a nurse is to advocate for patients and to encourage patients, especially vulnerable populations, so the people that are very ill, or very elderly, or that have autoimmune disorders, to get the vaccination. So flu season typically runs from October to March. Encouraging people to get that vaccination is going to be their best bet to avoid getting flu. Now, we create vaccines based on the projected strains of flu, the A and B, that we're going to be dealing with. And sometimes we miss the mark because it does change and it mutates every year. That's why we have some flu seasons in which the vaccine is effective and others where it doesn't seem to work at all. And it's because we didn't guess right. We didn't make the correct preparation. The second big viral respiratory disorder, in addition to influenza, is RSV. So that is respiratory syncytial virus, and it affects children and infants most of the time. Ribavirin or Virazole is used to treat that virus, and it can be pretty significant, pretty impacting to the health of a child or infant. Antituberculin medications are used to treat tuberculosis, which is caused by a bacteria, Mycobacterium tuberculosis. We've known of and treated TB for years and years and years. Recently, though, we are developing resistant strains due to noncompliance in drug treatment. This is really bad. This is a huge deal. Resistant strains of tuberculosis are fatal, and in some countries, not so much in the United States, they're really making insurgents. So the thing with treatment for tuberculosis is it's treated with IV antibiotics, specific antibiotics for a time of 6 to 12 months, and they're going to take 2 to 4 antibiotics at a time. I said IV, also PO antibiotics are used as well. So IV or PO antibiotics. So prophylactic treatment, if you were merely exposed to TB, is going to be 6 to 9 months. And if you're treating active or latent disease, it's going to be 9 to 12 months. And at the end of that time, if you still have evidence that the disease is not entirely treated, it might be extended beyond that. It would not be unheard of for somebody to be on treatment for TB for up to 2 years. So, based on all of that, you can guess or understand non-compliance to this very long drug regimen is huge. TB treatment is associated with DOT, which is direct observation therapy. So we can actually say, you have to come in to this local health department, to this doctor's office, to this designated site and receive your medication. If not, the individual could be essentially forced to do so. It's very important that people adhere to their treatment regimen for TB because it is such an easily spread disease if it's in the active respiratory form. So we do enforce DOT. Most of the time, people are allowed to take their medication at home, and they're just checked on regularly to ensure that they're being compliant. If there is any issue with non-compliance, or if we suspect that the patient may not be compliant to drugs, so the statement right from the beginning, like, oh my gosh, that's a really long time, I don't know if I could do that, they're going to be put on DOT where they come in regularly and get their administration. So it's just that big of a deal. The gold standard for treatment are basically 2 drugs, rifampin and isoniazid, which is also known as INH. There is some important teaching that goes along with these 2 medications specifically. Rifampin, which is known as brand name Rifadin, is also used to treat Hansen's disease, which is leprosy, and that bacterium is Mycobacterium leprae, so it's kind of a cousin of TB. If they are on this medication for any reason, you need to educate your patient that their urine, tears, saliva, sweat, their sputum, their bodily fluids are going to turn a really deep, dark red-orange. This can be pretty alarming if they're not given a heads up. And it's not if it happens, it does happen when they're on rifampin. INH is used to treat active disease, and it's also the drug of choice for prophylaxis. So if you have somebody that tests positive in a family, that person that tested positive will be on the year-long treatment of the two different drugs, but it's possible that the remaining family members might get a combination of the drugs or might just be on INH for a 6-month treatment. When on INH, they cannot have any of those tyramine containing foods. So remember, those are those aged foods like beer and cheese and chocolate and things like that. It can cause a hypertensive crisis. There's two more important things to remember about INH. That toxicity is a real issue with this drug and has to be monitored. The first sign and symptom that should be reported immediately is peripheral neuropathy. The other big issue with INH is severe and sometimes fatal hepatitis might occur because of the hepatotoxicity and damage to the liver that might happen with this medication. In addition to these two drugs, other drugs might be added. The two most common that make up the 2 to 4 are the ethambutol and streptomycin. Anticoagulants are included in this discussion because of their treatment capabilities for PE. So pulmonary emboli can cause extreme respiratory distress and will present as chest pain with an impending sense of doom. The way anticoagulants work is they don't actually dissolve clots or get rid of clots. They interrupt the production of clotting factors controlled by vitamin K. So for warfarin or Coumadin specifically, it decreases the body's vitamin K levels, thereby decreasing clotting that's occurring. So when someone is given Coumadin for the management of a clotting disorder, even though it doesn't eliminate the clot itself, it prevents the clot from growing, it prevents other clots from forming, and it allows the body to start breaking that clot down. Warfarin is monitored by the lab PT-INR, and because it works by affecting vitamin K, you have got to educate your patients that they need to avoid eating leafy greens and those foods that contain high levels of vitamin K, because you will essentially reverse the effects of Coumadin and they could develop life-threatening blood clots. The anticoagulants, heparin and enoxaparin, which is Lovenox, work a little bit different in that they block thrombin and fibrin from forming clots. So even if vitamin K activates the clotting factors, these drugs work on specifically just blocking the clotting factors from forming clots. Heparin cannot be given PO. These medications are only available IV or sub-Q. Coumadin, I failed to mention, is most often 99% of the time administered orally, but there actually is injectable forms. Heparin is destroyed by the stomach acid, so if it were to be created in an oral medication, it would be essentially rendered useless if it was given orally. Heparin is monitored by the PTT, which monitors a specific clotting factor, the thrombin clotting factor, or the anti-XA, which is becoming much more popular and is a new, more sensitive test. The anti-XA actually gives you the result of the plasma level of heparin or enoxaparin present in the plasma. So you can see how that is a lot more sensitive and a lot more accurate. So that's for heparin monitoring. Now, enoxaparin or Lovenox does not require routine blood monitoring, but if it did for a specific case that was high-risk bleed, you would want to use the anti-XA. The PTT is not near sensitive enough to give you an accurate monitoring. The thing about heparin is it has an incredibly short half-life. So whenever somebody is started on anticoagulants, anticoagulant therapy, they will almost always be started on heparin or enoxaparin first because it goes to work immediately. Then concurrently, they will be started on warfarin. So they'll also start taking a warfarin pill, and we'll monitor their PT-INR until that warfarin becomes therapeutic. It takes a whole lot longer for warfarin to start working. At the point that the Coumadin is effective, then we would be able to stop the heparin or enoxaparin administration. Just to kind of give you some perspective of the half-life of these medication, heparin has a half-life of about 1 hour, truly. Again, it depends on the size of the person and dosing and that kind of thing, of course, but we can stop heparin a mere 6 to 12 hours, and actually in some high-risk cases up to 1 hour before a major surgery, and they're going to be okay. We're not going to see significant bleeding. So for surgeries like replacement of a heart valve where the person has to be anticoagulated, they would be put on heparin prior to that surgery, and then it would only be stopped right before the surgery. Those replacement valves can clot in a matter of hours, and we would not want to leave them unprotected while they had surgery. Lovenox or enoxaparin has a very short half-life. It's called a low molecular weight heparin, so it's very similar, if not virtually the same as heparin. It is given subcutaneously as an injection in the abdomen, and it has a half-life of about 4.5 hours. So it also can be given very closely to procedures that might cause bleeding, as long as we stop it in adequate time for the half-life to pass. Now, Coumadin, on the other side, has a half-life of 20 to 60 hours. So while it takes a long time for it to develop a therapeutic level in the body, it also remains therapeutic or supratherapeutic if your INR gets too high for an extended period of time, and it would be stopped at least 5 days before a surgery. If the person required anticoagulant coverage, then of course they would be switched over to heparin during that 5-day period, and we would stop it a mere, few hours before surgery, so that we weren't leaving them without some sort of anticoagulant. Now, the big thing, of course, with any anticoagulant is that you're going to be monitoring the patient for bleeding. You're going to do all those teaching tips that you recall from pharmacology, such as making sure that they don't shave with straight razors and those kind of things, that they're using the little electronic razors, because even micro abrasions can cause significant bleeding. Tell them to use a soft toothbrush. A firm toothbrush can cause significant bleeding in the gums. So enough on that. Definitely make sure that you monitor for bleeding. If for some reason we need to do a reversal, we would reverse warfarin with vitamin K, such as if they started significantly bleeding or we needed to reverse quickly for an emergent surgery, we would administer vitamin K. Protamine sulfate is the quote-unquote or reversal antidote or reversal agent for heparin, and then sometimes desmopressin acetate, DDAVP, is used for the reversal of anticoagulants. But remember vitamin K and protamine sulfate. Those are the big ones that are used. I just wanted to touch really briefly on something that can develop as a result of anticoagulants. Heparin-induced thrombocytopenia can occur, in which the platelets are so lowered by the administration of heparin that the person becomes very thrombocytopenic, and they're sensitive to heparin in a way that it's not therapeutic, it's dangerous. Argatroban is the anticoagulant that can be used in this case. It's the brand name Acova. Argatroban might also be used in renal patients, even if they don't have HIT, because it's not excreted in the kidney, so it doesn't require dosing adjustment based on dialysis. Coumadin does not cause heparin-induced thrombocytopenia, so it is safe. And if someone's on long-term therapy, that of course is the drug that they're going to be on. I wanted to talk about correct administration of enoxaparin or Lovenox because sometimes it gets mixed up or administered wrong. Lovenox comes in a pre-filled syringe with the medication ready to go for subcutaneous administration. You don't have to draw it up. You don't have to measure it. Inside of that syringe is a air bubble that comes from the manufacturer. You do not express that air bubble. Don't tip the needle up in the air, flick it to the top, and express it from the syringe. In fact, you want to point the needle downward and make sure that that air bubble is at the very top or closest to the plunger. When administering enoxaparin, you're going to give it in the abdomen. We say pinch an inch, so you want to get a good pinch of abdominal tissue to administer in. You do not want to give it within 1 inch of the umbilicus, so stay away from that. You want to give Lovenox at a 90-degree angle at all times unless the person is incredibly thin and you're not able to pinch up adequate subcutaneous tissue for the length of the needle, then you can use a 45. But 99% of the time, you want to use a 90-degree angle. We want the enoxaparin to be administered deep sub-Q. So when you when you insert the needle at a 90-degree angle, you will inject the medication, and the last thing to go in will be that air bubble, and it's going to push the medication deeper down into the subcutaneous tissue, kind of like the reason we do a Z-track method to make sure that it doesn't come back up to the surface, and in this case, so that it doesn't cause surface or superficial hemorrhaging or bleeding. So we want it deep in the subcutaneous tissue where it's best absorbed. After holding the needle there for a few seconds, you're going to remove it and you're going to push a little bit harder on that plunger with that same hand you were holding it with, and it's going to activate the safety device, which is going to pop out over the needle. You can then let go of the abdomen. You're not going to want to wipe or clean it with any alcohol that might burn after administration. Of course, you can do it before. And then you'll want to dispose of that needle right into the sharps container. So that is the appropriate way to administer enoxaparin. And while this doesn't directly relate to respiratory disorders, it is relevant to pulmonary embolism. I wanted to touch on antiplatelet and thrombolytics. Antiplatelets are going to be used as preventative medications that prevent clotting that might lead to pulmonary embolism. So if we have a clot that develops somewhere in the body, it could travel and become lodged in the lung, creating a pulmonary emboli. This is going to include aspirin, clopidogrel, which is Plavix, and trifibin, which is Aggrastat. These are going to be antiplatelets or antiplatelet aggregates. So to aggregate something means to mix it and stick it, and it comes together and it forms something new. So that's why concrete places are called aggregates, and so you're taking rock, sand, and that kind of thing. You're aggregating it together and you're creating concrete. So if our platelets aggregate together and create concrete, that's a clot. So these medications keep the platelets from sticking together and from aggregating. So that's what an antiplatelet aggregate does. We do want to monitor for bleeding with these. It's a little bit less significant than on our anticoagulants that we just talked about, but still something that you want to keep an eye on. Now, thrombolytics are used in the treatment of PE. So this is the only true clot buster. Like I said before, our anticoagulants actually don't break down the clot. It simply prevents it from growing, from new clots from forming, and allows the body to start breaking it down and dissolving it. So a thrombolytic is the only true clot buster. And so thrombo being the clot and a lytic meaning killing or destroying. These are risky because it can cause hemorrhage. So it is a massive anticoagulant used to treat pulmonary emboli, myocardial infarction, and cerebrovascular accident or stroke. TPA, which is tissue plasminogen activator, is the most common, and this is what we push for CVA, and if given within 60 minutes, and recent studies are even supporting longer. I've read some stuff up to like 4 hours of the onset of CVA. The effects of that stroke are significantly reduced. So for a pulmonary embolism, if it was an especially large or dangerous one or was causing significant respiratory distress, we might use a thrombolytic to try to break up or reduce that clot. Typically, we're going to just go with the anticoagulant treatment that we described before, but this could certainly happen. As a side note, TPA is also known as alteplase, and we do instill this in central lines that are clotted or blocked off. So it's not administered systemically, but it's kind of used as Drano or a Roto-Rooter for those central lines that might be clogged or clotted off because of clot formation. So when we administer alteplase, we actually do withdraw it after it's done its job of clearing up that clot. So that's our respiratory meds that we hadn't covered in part 1.